Welcome to Diagnosing Health Care, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare. While these issues may seem like hurdles, we'll also look at the business opportunities and solutions that exist. Diagnosing Healthcare is brought to you by the healthcare lawyers at Epstein Becker Green, a leading law firm serving clients in the healthcare industry nationwide.
Today on Diagnosing Healthcare, we will discuss the expiration of the public health emergency and the impact that this will have on healthcare providers and organizations. Hello and welcome. I am your host, Dan Fahey. I'm an attorney in Epstein Becker Green's Healthcare and Life Sciences practice based out of our Chicago office. On January 31st, 2020, former Health and Human Services Secretary Alex Azar issued a determination that a public health emergency existed as a result of the 2019 novel coronavirus. Since that time, the declaration of the public health emergency has been renewed 12 times, but is finally set to expire on May 11th, 2023. In conjunction with the public health emergency, CMS and other federal agencies have issued waivers and other declarations with the goal of giving providers flexibility in order to render services during the PHE. Accordingly, providers and healthcare organizations must understand what impact the end of the public health emergency will have on their operations and how they should prepare for the expiration of the end of the public health emergency. On today's show, we're going to talk about the expiration of the public health emergency that has been in place since January of 2020 and discuss the impact this will have on stakeholders. Joining our discussion today is Jenny Nelson Carney, a member of the firm in Epstein Becker Green's Columbus office. Jenny helps hospitals, health systems, and other providers navigate complex regulatory issues with healthcare operations and state and federal healthcare policy issues. Welcome, Jenny.
Thank you. I'm glad to be here.
Also joining our discussion today is Amy Lerman. Amy is a member of the firm at EBG in our DC office. Amy advises clients on a wide range of matters involving government investigation, audits, and related claims of fraud, false claims, and non-compliant behavior. Also, Amy advises telehealth clients on the trends and the development of regulatory strategies for growing and expanding telehealth businesses. Welcome, Amy, and thank you so much for joining us.
Thank you for including me in today's discussion.
To start, let's time travel back to 2020 and discuss what the declaration of the public health emergency meant and what type of waivers came into play following the declaration. Amy, can you give us a sense or a brief recap of what these waivers meant and what went into place as of January of 2020?
Sure. As you said, the PHE was initially declared by Health and Human Services in January of 2020. That feels, I'm sure to all of you, like a lifetime ago. And as you had mentioned, the declaration of the PHE allowed both federal and state agencies, really across the spectrum, to put various types of waivers into place. In certain circumstances, generally, the PHE being a real prime example, the Secretary of HHS can utilize Section 1135 of the Social Security Act in order to temporarily modify or waive certain Medicare, Medicaid, CHIP, HIPAA requirements. We refer to these generally as 1135 waivers. We all got a quick and fairly extensive education on 1135 waivers when the PHE was declared. There were Medicare blanket waivers, there were individual provider 1135 waivers, even state-specific 1135 waivers. And what these waivers had the common purpose of ensuring, especially in the face of the PHE, was that beneficiaries under all of these different programs could continue to do things that would continue to ensure that they were able to access the care that they need. I'm just quickly taking CMS, the Centers for Medicare and Medicaid Services, as an example, because this really went across the spectrum. But in CMS's case, the agency used a combination of emergency authorization waivers, regulations, sub-regulatory guidance to ensure and expand access to care, and to really give healthcare providers the flexibilities they needed to keep the healthcare system moving, but also while doing so to keep people safe. So the waivers that were initially put into place affected care delivery, coverage and payment for services, the ongoing operations of providing patient care, and allowing providers and healthcare systems to keep their doors, both virtual and otherwise, open. And so CMS incorporated all these waivers and really, for the first time, allowed beneficiaries, big in my world, to take advantage of telehealth services. While telehealth services were covered by Medicare prior to the PHE, it was like an entirely different ballgame once the PHE was declared. And these waivers and other flexibilities in the telehealth context allowed greater coverage and reimbursement under Medicare for many, many more services when they were being provided by telehealth. They've allowed coverage when beneficiaries receive these services in their homes and in some other locations where coverage was previously not allowed under the traditional regime. They have allowed coverage where beneficiaries access these services using a much broader range of technologies, including audio-only phone calls. And Medicare has made no secret of the fact that they've been watching utilization of telehealth services very carefully throughout the PHE, with an eye since really the beginning toward decisions they hope to make, and I think are starting to make, about what flexibilities could become a permanent part of the program's coverage and reimbursement schemes for these services.
Wonderful. Thank you, Amy, for that helpful background and context. I think healthcare leaders and providers were obviously very busy during the pandemic and the public health emergency, but CMS was busy too, and they were publishing fact sheets throughout to provide guidance to lawyers like ourselves and others to understand what waivers were in place. And most recently, they've published fact sheets to identify what waivers will terminate at the end of the public health emergency. Some of these waivers are narrow, such as waiving certain paperwork requirements, while other waivers have large implications, such as expanding the use of hospital beds. Jenny, can you give the listeners just a sense of some of the key waivers that will terminate at the end of the public health emergency?
Sure. So before I discuss a few specific waivers, I think it's important to think about why the waivers are terminating. As both Dan and Amy mentioned, the waivers were put into place so that providers had flexibilities during the pandemic to continue to provide the healthcare services that beneficiaries needed. And while these waivers were very useful for those flexibilities, CMS has observed over that time a decline in patient safety and is afraid that continued flexibilities could contribute to further decline. The CMS, of course, is quick to say that they understand and appreciate the significant efforts that providers, both individual and organizational, have put forward during the pandemic under unprecedented circumstances. But still, when they trend patient safety benchmarks, they have seen a decline. So if a waiver that is currently in place isn't one that they have learned or that we have learned as an industry provides better care or better access to care, it is likely to be terminated at the end of the PHE. We could probably argue a couple of them, and as healthcare providers and representatives of people providing healthcare to patients, we may say, no, we wish this one would still stay in place. But it's important to understand the eye to which CMS looks at these waivers and considers whether they should stay in place. So from a patient safety perspective, one of the most significant waivers that will terminate is the hospitals without walls or temporary expansion site waiver. This allowed hospitals to provide hospital services in sites that otherwise would not be considered a part of a healthcare facility, or to set up these temporary expansion sites in buildings and places where healthcare services were not previously provided in any stretch, such as convention centers and arenas and things like that. When the PHE ends, hospitals will be required to provide services to patients within their hospital departments and pursuant to the conditions of participation, which was that was the regulatory framework that we had existing prior to the PHE, prior to the waiver of so many pieces of the COPs. So that's a significant one. Relatedly, CMS permitted ambulatory surgery centers or ASCs to temporarily enroll as hospitals. I suppose that it's actually a re-enrollment because these ASCs were enrolled in Medicare, but they were allowed to re-enroll as hospitals so that they could provide hospital services to beneficiaries, specifically COVID beneficiaries, and particularly when we were hitting huge surges of COVID. We needed more spaces and more providers to provide healthcare. So they allowed the ASCs to become hospitals temporarily. When the PHE ends, ASCs must decide whether to meet the full hospital certification standards and become a hospital or return to their ASC standard. They can't stay as a temporary hospital like they've been able to do the last couple of years. Another patient safety focused waiver was specific to EMTALA, the Federal Law Emergency Medical Treatment and Labor Act. CMS partially waived the enforcement of EMTALA to allow hospitals to screen patients at a location offsite from the hospital's campus. And this was really with the intention of preventing further COVID spread. So they let hospitals perform this service farther out from the hospital than they normally would. It wasn't contained just in the emergency department. They could do it at a location off-site. This is another waiver that will terminate at the end of the PHE, and hospitals will resume their normal conformance with the EMTALA rules. Finally, one other one I wanted to point out that we saw a lot of use of, especially early on, is surrounding verbal orders. CMS has been allowing authentication of verbal orders to occur later than 48 hours, which allowed for more efficient treatment of patients in surge situations. But this is also a waiver that will come at the conclusion of a PHE. And I mentioned this one because I think it's one where even in normal circumstances, sometimes providers have trouble with enforcement. And so we don't want to forget that this CMS's flexibility here was pursuant to the PHE and not something that they intend to let slide moving forward. Outside of a patient safety perspective, I wanted to mention two waivers. One with regard to vaccines. We had COVID vaccines available without cost sharing and effective January 1st of 2024. So a little different. It's not at the exact end of the PHE, but it's January 1st of the year immediately following the year in which the PHE ends. So effective January 1st, 2024, CMS will set a payment rate for administering COVID vaccines to align with payment rates for administering other Part B preventative vaccines, which really means they're just taking the COVID vaccine and putting it in the bucket with all the other vaccines that they pay for or those payment frameworks. They're making it just sort of a part of routine preventative healthcare. And then the last one I wanted to mention, this was a huge one for many of our healthcare providers. CMS permitted certain referrals and submission of related claims that would otherwise violate the Stark Law during the PHE. So these were the Stark Law waivers. Example, hospitals and other healthcare providers could pay above or below fair market value for personal services of a physician. Parties could pay below fair market value to rent equipment or purchase items or services. Again, these flexibilities were things that CMS anticipated and saw providers needed in order to provide the services that were required during the pandemic, especially during surge situations. We also saw under the Stark waivers, hospitals could provide benefits to their medical staff, such as daily meals, laundry services, childcare, things that normally wouldn't necessarily fit under Stark. There was just much more flexibility under Stark during the PHE. And when the PHE ends, the Stark waivers will terminate and physicians and entities must immediately comply with all the provisions of the Stark Law. So we really want to emphasize this one because we think this one got a lot of use and we want to make sure that providers are paying attention to the fact that it's coming to the end.
That's great. Thank you, Jenny. Yeah, I think that is a good highlight of some of the key waivers. Obviously, there's many others, and shameless plug, but our Health Law Advisor blog will continue to discuss and we'll write about the waivers that will be coming to an end and terminating here. And we'll continue to write on these topics and provide more in-depth analysis on some of the waivers that people should be thinking about that will terminate at the end of the public health emergency. Transitioning, Amy, you had mentioned your telehealth practice and the telehealth guru. Telehealth took off during the public health emergency, and many states implemented waivers at the state level to permit providers to render services across state lines, even if the provider was not licensed in that state. The goal was obviously to provide flexibility and be able to help triage services during the height of the pandemic. Do you expect consumers will continue to utilize telehealth, and have the states or federal government implemented any permanent waivers that might support this type of service?
It's a great question. Even just to take half a step back, because I think we still have to time travel a little bit back to 2020, because a very important distinction that I think it took providers and the industry at large a little bit of time to understand were the differences between, Dan, as you referenced, federal flexibilities and state level flexibilities. And waivers certainly related to professional licensure, to use your example, that really topped the list. A number of questions came in right off the bat about, this is what the federal government is saying, that means we can do this. And we had to say, wait, there's a difference between the federal government and the state government. And in this case, with respect to licensure, the federal government, by and large, did not have the ability to, for example, decide that in a particular state, physicians, for example, either could practice without obtaining a license from the state, provided they held a license in some other state, or could avail themselves of some other sort of flexibility with respect to their license. Obviously, the flexibilities that generally were being promoted, as you said, Dan, were to, promote cross-state practice and greater flexibility, in this case, to be able to utilize telehealth services. But very importantly, it was a state-by-state decision that states did ultimately make quickly, but it was always a flexibility that states, not only were able to be the ones to make, but they were in control of, and they had the power to take it away. And so pre-pandemic, we had some states utilizing special telehealth licenses already, and there was a growing interest as well, separately, in professional compacts. We had the Interstate Medical Licensure Compact, the Nurse Licensure Compact, SIPAC for psychologists. And those were ways pre-pandemic that the industry was trying to promote cross-state practice at the state level. And I think those things were certainly added to during the pandemic with the flexibilities that states then gave for a temporary amount of time, either to completely waive a professional licensure requirement, or I think we saw in many more cases, not that someone could just rush into a state without a license, but certainly that the state was going to make it much easier for the professional to obtain a license in that state in order to practice most often via telehealth. And, now what we're seeing, many of those waivers and flexibilities have gone away, and they have been gone for a while. We do have some states that have implemented permanent telehealth registrations. Florida, Indiana, West Virginia are some examples. And I think we're seeing other states considering it. And we're also back to some of these other alternatives that states are continuing to promote as the state-specific waivers and flexibilities have expired and they have not been renewed. The general goal continues to be, especially in the telehealth context, to be able to promote cross-state practice, but states, I think, have reasserted, and I don't think really ever lost their ability to say this is under our control and we want to control the care that's being provided within our borders. You also mentioned Medicare. Medicare, as I had mentioned before, took huge steps during the public health emergency to expand coverage and reimbursement opportunities for telehealth providers. And CMS has definitely been watching these flexibilities so they can decide, and they've said that as much, very clearly. They know that their traditional coverage and reimbursement framework for telehealth under Medicare needed to change and needs to in some way now permanently change as a result of everything that happened during the pandemic. The Consolidated Appropriations Act of 2023 extended many of the telehealth flexibilities that were authorized during the pandemic through the end of December of 2024. Personally, I think this extended timeline is great. It gives Medicare and the program a reasonable runway to continue exploring how the program can evolve and more permanently, expand to cover greater amounts of telehealth services, more flexibility for how people can receive those services. And I do, to answer your question, think consumers will continue to utilize telehealth once the public health emergency ends in May. Pre-pandemic, telehealth's biggest challenge was utilization. Heavy fascination, I think, by many in what the industry was doing, but a lot of hesitation on the part of consumers to actually try to use the services themselves. I think the pandemic has helped that, getting many consumers, individual consumers, over that hump and using the services and seeing their benefit, certainly in certain situations. And so I think we've got nowhere to go but up in this regard, especially if consumers know it's a modality of care that it's going to continue to be supported more broadly by payers, Medicare and otherwise.
Great. Thank you, Amy. Not only did telehealth use increase, but Medicaid enrollment increased dramatically during the pandemic. And one reason for this was the continuous enrollment provision that was part of the Public Health Emergency Declaration, in which states received additional federal funding for not taking away Medicaid coverage from enrolled beneficiaries during the PHE. Jenny, what does the termination of the public health emergency mean for Medicaid beneficiaries and state Medicaid programs?
Yeah, there's going to be a significant impact to the Medicaid rolls. So just to back up for a minute, in 2020, the federal government passed the Families First Coronavirus Response Act, which when I was preparing for the podcast and thinking about that, I was reflecting on how we haven't used the term coronavirus much recently, but that was such a thing back in 2020. For a while now, it's been COVID-19. But this act was the Families First Coronavirus Response Act. And that act provided states with an enhanced federal matching rate of 6.2%. But in exchange for receiving that, states were then prohibited from disenrolling Medicaid beneficiaries who had been enrolled in Medicaid as of March 18th of 2020, even if they determined that those beneficiaries were ineligible. So that's the concept of the continuous enrollment phrasing that we're using now. And as we've said several times during this podcast, the intent behind that was to ensure that beneficiaries did not lose vital healthcare coverage during the pandemic. Fast forward to this year, under the Consolidated Appropriations Act of 2023, continuous enrollment will come to an end at the end of March. So March 31st, 2023, we will see an end to continuous enrollment. The temporary enhanced federal matching rate that I referenced will gradually be reduced and phased down beginning the next day, April 1st, and then that will end completely at the end of the year, December 31st. So what that means is then beginning April 1st, states will be able to terminate Medicaid enrollment for individuals who are not eligible. States will have up to 12 months to initiate and 14 months in total to complete a renewal for all individuals enrolled in Medicaid, CHIP, and the basic health program following the end of this continuous enrollment condition. And you may hear this referred to as the unwinding process or just the unwinding. So this is going to result in a really significant number of Medicaid beneficiaries being disenrolled from the program. And I've seen numbers anywhere from 5 to 14 million people that are likely to lose Medicaid coverage during the unwinding period, even though some of them may still be eligible. The chunk of people that are still eligible may lose coverage just due to the administrative burdens and hurdles of the unwinding and the need to re-enroll. But the people that lose Medicaid coverage and cannot access it again will need to transition to other sources of healthcare coverage. And we expect a big chunk of them to qualify for Affordable Care Act marketplace tax credits. So with that in mind, CMS announced that there will be a special enrollment period on the marketplace to assist individuals who are losing their Medicaid coverage due to this unwinding. This is a significant impact to Medicaid beneficiaries who have been able to have significant stability with their healthcare coverage over the last 3 years. It also will impact providers as they need to be aware that many of their patients will have changing payer status when they come in, and there will likely be some administrative and paperwork hurdles associated with that. And then obviously this will impact payers as the states are dealing with it from a Medicaid perspective, who's still covered, who's not covered. And I would expect to see a lot of administrative struggle there. And then other payers will have likely an influx of Medicaid beneficiaries on their rolls. So that's what we expect to see in all those different areas.
Certainly a lot of activity around the winding down, and the federal government still trying to provide coverage to Medicaid beneficiaries. Amy, we obviously touched on telehealth, but one big development during the PHE was the DEA, the Drug Enforcement Agency, acted swiftly to waive the Ryan Haight Act in-person examination requirement for the prescribing of controlled substances. This ensured that millions of established and new patients were able to receive medically necessary prescriptions via telemedicine during the public health emergency. It's my understanding that there's been efforts to amend the Ryan Haight Act and implement a telemedicine registration before May 11, 2023. But however, assuming there is no action by the DEA or Congress between now and then, what will healthcare providers, including telehealth companies, need to do to effectively May 8th, assuming the Ryan Haight Act waiver is terminated?
As you said, during the public health emergency, providers had this tremendous and certainly never seen before ability to prescribe controlled substances via telehealth without doing an in-person examination as a precursor to issuing these prescriptions. It is, as you mentioned, a waiver of requirements that were added back in 2008 to the Controlled Substance Act by way of those Ryan Haight amendments you referenced. And to be clear, what those amendments said way back in 2008, it called on DEA, it gave DEA the ability to implement a special telemedicine registration. And the level set, even before the public health emergency, there has been tremendous pressure from the industry, providers, everyone for DEA to take action. And there were some other, attempts at action, leading up to January of 2020. But in January of 2020, DEA was able to take advantage of yet another exception to the Ryan Haight, the Controlled Substance Act by putting in the emergency waiver that it is allowed to do. So when things expire on May 11th, and without further action by DEA, before that date, everything basically reverts. And as you said, continued prescribing for patients who have never been examined by the prescribing provider in person and only were examined by virtual means, that will be prohibited. Patients are going to either need to be seen in person. They may need to have their care transitioned to a local provider who could fulfill that in-person requirement. This puts a real strain on a business model that certainly during the pandemic has served providers of virtual services very well, has continued, as we've all been saying, to ensure that access access to care can continue, both in physical and mental health capacities, this is a very important requirement. And so it is a big deal for prescribers of these types of medications. And I say that we just don't honestly know what's going to happen leading up to and on May 11th. These are our best guesses. But in thinking ahead, providers should not be waiting until May 11th to see what actions DEA may take. If providers are not already doing so, now, if it's not already happening, is the time to engage in, any number of strategic business discussions, clinical decision-making, you name it. It should be talked about contingency plans. Should this in-person requirement revert, which we do expect it to, evaluate current prescribing practices, identify potential alternative approaches. I mean, it's certainly our hope that DEA and/or Congress may step in to come up with a better solution before May 11th, but it's equally likely that no meaningful action can be taken, at least fully. I mean, you could get into a rulemaking process, notice and comment. Those things, as we all know, take time. And so even if some action is kicked into gear before the date, it may not be finished before May 11th. And providers really need to be ready for this.
Wonderful. And I appreciate both of your time. We're going to finish. I'm going to ask two hard-hitting questions, one for each of you. Jenny, we talked a lot about what waivers are terminating and what providers will not be able to do as of May 11th when the public health emergency expires. However, can you explain to us what healthcare providers and organizations should be doing between now and then to prepare for the expiration of the public health emergency?
Sure. And that's a great transition from what Amy was just describing, because she was describing some important steps specific to DEA. But I'm going to go big picture with this, and really you'll hear the same themes. Most importantly, providers need to know what waivers they have utilized. That maybe sounds silly as a first step, but the public health emergency has been going on for so long at this point. And we know there's been so much turnover within the healthcare industry that some of the information that's been maintained by providers could be lost during that length of time and those turnovers. So you want to make sure that you have a full assessment of what waivers that you have utilized. We have plenty of client providers that have files and spreadsheets. A lot of it, though, is housed in people's minds. So don't wait too long. Don't wait till May 10th to try to assess what you have utilized. Do a comprehensive review and be able to say, here are the waivers we've utilized. We've already stopped utilizing these. Here are the ones we're still utilizing. And then once you know what waivers those are, you want to make sure you assemble the right team of SMEs, of your subject matter experts, who really understand how the waiver has been utilized in your organization, how it's affecting operations, how it's affecting provision of care, and how you can revert from using that waiver to pre-pandemic operations, or maybe new and creative operations that still meet the letter of the law without using the waiver. So the determination of how to provide care without use of the waiver is really the key consideration that you want to make prior to the waiver expiring. And then the last piece, and very important, document everything you're doing, so that if anybody comes back at any point, and when I say anybody, I mean the government in particular, and says, when did you stop using this waiver? Show us proof that you weren't using it in June of 2023. For example, you'll have documentation to show we were using it here. We stopped using it in February of 23 or May 10th of 2023. Just make sure you keep documentation of what you've done, so that if you ever need to prove your case, it's a lot easier when you have that documentation.
Great. Thank you, Jenny. That's very sound advice, and providers should act sooner than later so they avoid any unnecessary stressors. Amy, we've talked a lot about preparation for the expiration of the public health emergency, but do you have any thoughts in terms of what laws or enforcement trends that we might expect to see following the termination of the public health emergency on the other side of this?
Well, I'm going to go telehealth, but I think this more applies generally as well. Remember when I said at the beginning of this that Medicare, as the example of a payer, is watching? Payers, enforcers, everybody is watching, and not just watching, but they've been collecting a lot of data over the last 3 years. And I think that what we've seen, good and bad, is an uptick in this data collection we're seeing it, I think, most notably with respect to payers. But I think we also have seen even so far, a gradual movement in the enforcement realm. Various agencies during the public health emergency made it really clear that they were going to be exercising enforcement discretion in various respects. Jenny mentioned Stark waivers, copays, on and on and on, prescribing. And so I think that as we get to the end of this public health emergency and things are going to be reverted or things are going to reverse course, we're going to be seeing trends in enforcement that follow those trends. So watch this space. And, but there's already been enforcement activity related to prescribing practices. Jenny mentioned documentation. I think we've already seen from the payer contractor side of things, an uptick in audits that, at least specific to telehealth, are looking at the utilization of telehealth services and how things are being documented and whether proper consents are being obtained and are these services medically necessary. So I think it's a lot of, the things that we typically see and work with our clients to handle. But I think that it's going to become all that more important as waivers expire. And as Jenny said, things that haven't been carefully documented, use of waivers and just practices that providers in the industry have fallen into because of waivers and flexibilities. I think we're seeing the beginning of this and it's going on, and we're going to continue to see it in OIG, DOJ, DEA, you name it. I think everybody has their set of data, they're tracking it, and we should expect that, our clients are going to be hearing from agencies when data looks off or something else happens. There's an anomaly. So watch this space, certainly from an enforcement perspective.
Great. Thank you, Amy. Thank you both for your time. And thank you to all of our listeners. I am your host, Dan Fahey. If you like what you heard today, please do not forget to subscribe to Diagnosing Health Care. And as we previously said, we will be continuing to write on this topic and what providers and organizations should be thinking about as the public health emergency comes to an end. So please look out for our writings at Health Law Advisor. And thank you again for listening.
Thank you for listening to Diagnosing Healthcare. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. The Employment Law This Week and Diagnosing Healthcare podcasts are presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of the legal services to be performed is greater than the quality of legal services performed by other lawyers.